All right, well, my name is Jen Killian. I'm a Lieutenant Community Resource Paramedic with East Pierce Fire and Rescue, and it is my pleasure to introduce Matt Santelli. Matt is with the Pierce County Aging and Disability Resource Center, and this is the sixth of our 6-class series on aging and care planning. Matt, I've worked with Matt now for a few years, and Matt is just a tremendous wealth of information. He's gone through these things within his own family and has helped many, many, many people through these. So I welcome you here today, and to those online, thank you so much for joining us. If you're online and you have questions, feel free to type them into the chat, and I will ask them when we're ready. All right, Matt, thank you.
Right, thank you. Thanks everyone for being here. I put a lot of resource information on the back table there, and I'll go over a few of them, but a lot of them relate to some upcoming events and services we have going on. So please, when you're done, if those of you in the room, take some information there. A couple of things you'll find on the table in terms of programs and upcoming events. The Tacoma Housing Authority is opening their Section 8 and Housing Authority building waitlist on November 14th this month. For those folks, friends or family members you have that are looking for income-based rent, which everybody's looking for nowadays because rents are so high, please grab one of those flyers when you leave and pass that on to them. There's also a Thanksgiving turkey giveaway and grocery giveaway coming up in different locations around Tacoma. So if you know anyone that lives in the Tacoma area, it's open to anyone in Pierce County. But most of the 3 drive-through locations are in Tacoma. So if you have anyone that's struggling with putting their Thanksgiving meal together, please pick up those flyers too. You'll also find our county brochure here. It's front back kiosk card for the Aging and Disability Resource Center. That's where I work. Our phone number is 253-798-4600. So you're welcome to pick up one of these. If you have any questions about programs, services, anything related to what we talk about today, countywide, statewide even, or even if you have a friend or family member living in another state and might have some concerns having spoken with them, if they're senior or disabled, please give us a call. We can get you attached to programs and services here in Pierce County. There's similar programs statewide, and then nationwide, there's equivalent offices like ours in other states. So if you call and say, well, my cousin Susie's living in Nebraska, and this is the problem she seems to be having, if you call us, we can get you some information on the local office like ours in that other state. One program we're always promoting with regards to these talks is our family caregiver support program. This is a program really designed to give relief to family caregivers. It's typically husbands taking care of wives or partners taking care of one another as they get older. And it gives 24 hours of relief care into the home. It gives some housework and errand services, provides some medical equipment. And this is a non-Medicaid program. So even if you have some assets, some money in the bank investments, we don't even look at those. We just look at the household income. And it can go as high as a married couple's household income of $4,500 a month, and it's still no cost. So again, if it's you or you have a friend or family member taking care of another family member and they're wearing down a little bit as a result of that, please have them give us a call so we can assess whether they might be right for this program. It's designed to be a scheduled relief program. So once you get started, so that person who's providing the care would know on every Tuesday, Thursday, for example, someone from a licensed, bonded, insured agency would be there at 1 o'clock to give them some relief. Then they can leave the home, go to their own appointments, whatever they might do. So this is on the table as well. Also, we have information on our Veterans Assistance Programs. We have a County Veteran Service Office. So folks don't have to go all the way out to the American Legion VA. It's right in our county office on Pacific Avenue there. And a lot of the services now being provided are looking at disability claims. There was what's known as a PACT legislation, which was passed through Congress a few years back. That's opening up a lot of disability for claims for folks, service people who may have been denied years ago, and are getting approved for these pensions. My colleague at work, Lindsay, her dad was approved on this. He had been denied multiple times back in the 70s for his service, and now he's getting a good disability pension to help with his monthly budget. So please give us a call if you want to come in, have a benefits review if you're a veteran or a spouse of a veteran, or you can just walk in if you need to. Also have a brand new off the presses, Where to Turn yellow booklets. You see these around town. A lot of people have the older versions of these. This is the current version, 2024 to 2025. So feel free to take this off the table, take one for a friend. I brought a stack. And also take our Stepping Ahead Falls Prevention Coalition trifold brochure. Has a lot of great information about fall prevention and home safety, fall prevention and what your risk factors are. It's a really nice brochure to have out and about in the community. So again, take a few if you have a friend or family member you know that's at risk for falling. We're really heading into that fall risk period of the year with bad weather, slick roadways, roads and sidewalks, debris on the road, things like that. So we really want to make sure people avoid falling. As we get older, the number one reason you'll probably end up in an emergency room is from a fall. My own wife, this last August, she was working in the yard, just finished up. She turned to come back into the house, fell in the landscaping, broke her wrist, was in a cast all the way past her elbow for 2 months. Thankfully, she didn't have surgery. Thankfully, she's rehabbing it and getting all of her mobility back. But we've talked to other people, fallen in the yard, broken wrists, broken shoulders, hips, everything like that. So as you head into this winter season, again, those risks are still there, if not bigger. So take this brochure as well. And then finally, we have on the table, and again, take one for yourself or a friend or family member, our File of Life brochures. This is a brochure where you put all your information in these white pages, put it back in the pouch. It has a magnetic strip on the back, and then you go ahead and hang it on your refrigerator or some magnetic surface in your kitchen. And this is one that first responders like Jen's colleagues here really look for, because if they go out, and especially if you're living alone, and you've had a medical emergency, you're not going to be able to tell them all your illnesses, injuries, allergies, all those things. So please take one of these. It can really be a lifesaver for you. Take one for a friend or family member as well. Great, thank you. Okay, so let's go and get started in the talk here. I gave you the handouts, which are the copies of the PowerPoint. And then there's another handout about Medicare. And then another handout that kind of goes through end-of-life situations a little bit. So we'll go through the PowerPoint first, and then if you have questions, just feel free to raise your hand. It's a small group, so we can answer questions as we go. We entitled this talk, Understanding Palliative Care and Hospice. We'll explain what those are. That's my name, my contact information. There's also a resource contact information page at the end of the PowerPoint as well. So the disclaimer I always give is we're not recommending any specific treatment program for you as individuals or your family members. We're not going to go over every possible situation where palliative care and hospice might be the right choice. We always remind you to consult with your physician to determine the best plan to address the care needs for yourself and your loved ones as well. In this hospice and palliative care world, it's really important that everybody as much as possible understand what it all means. My wife's had a friend in Ocean Shores who's been on hospice, and some of the family members didn't quite know what that meant in terms of her care, because in the hospice world, you really talk to your hospice care team before you talk to emergency services or 911 and things like that. So it's really important for everyone who's kind of working with that family member or friend and caring for them that they all understand kind of the pattern of hospice. And I'm going to have Jen chime in too as we talk, because she's got a lot of experience working up front and up close direct service with the hospice population as well. Okay, so this is kind of what our PowerPoint talk will be about, talking about end-of-life care, what it is versus palliative care and hospice care being the two elements there, whether Medicare and Medicare Advantage plans pay for it, does Medicaid pay for it, commercial insurance, veteran services, what legal documents should you have in place for your end-of-life care, and what resources are available for more information. And the legal documents, we had a much more comprehensive presentation about the legal documents. If you go on the East Pierce Fire and Rescue website under events, you can see all of those different talks that we did, and they're all available for you to watch or listen to from the website at no charge. So. Okay. So understanding need for end-of-life care. So when we talk about end-of-life care, that's the term we use to describe support and medical care given during the time surrounding death. It's a type of care that's not happen only in the moments before breathing ceases and the heart stops beating. Older people often living with one or more chronic illness and need significant care for days, weeks, and even months before death. So it's really more of an art than a science, because we'll talk about how it's determined that you go on hospice care. And people are always thinking, well, that just means I'm dying, I'm going to die soon. That's not necessarily true. My mother-in-law was on and off hospice care for 3 years. So determining end-of-life timelines is really more art than science. It's not specific where a doctor would be treating you and say, in 1 week, you're going to die, you know. The one situation I think that kind of marks that was my mom. Late in her life, she was unconscious and living in a skilled nursing facility. There wasn't any assessment that she was under a great deal of pain, so she wasn't receiving morphine or anything like that to keep her comfortable. But they were trying to keep her going, which is what skilled nursing facilities do, trying to keep people alive by providing her with IV fluids. The hospice care assessment was the IV fluids were not doing anything for her. They were just bloating out her body because at that point her body was wanting to shut down. So they basically told the treatment team at the skilled nursing facility, let's stop giving her the IV fluids. And in my mom's living will, that was one of the treatment aspects of it that she agreed upon, was that if she was in an end of life situation, she didn't want artificial nutrition and hydration to try to keep her alive. So they told us on that Wednesday, your mom will probably be dead within a week, because once we remove hydration, the body's going to not be able to sustain itself any longer. Sure enough, 1 week from that day, I got the call that morning that my mom had passed away. So in certain situations, it's pretty evident how long a person might live. But if you're someone that's undergoing treatment and you've been kind of failing in treatment and they tell you, you may have 6 months to live, you're going to go on hospice, that's not necessarily specific to that timeline. The timeline can certainly change in different situations. End of life may look different depending upon the person's preferences, needs, and choices. Some folks may want to be at home when they die. Others may prefer to seek treatment to a hospital or facility until the very end. Many want to be surrounded by family and friends, but it's common for some to slip away while their loved ones aren't in the room. That's what happened with my mom. She was in the care facility overnight and my dad was there, but he was sleeping in another room there. So he went to bed and then they woke him in the morning to say that she had passed away overnight. When possible, there are steps you can take to increase likelihood of a peaceful death for your loved one following their end of life wishes, and treat them with respect while they're dying. Okay, generally speaking, people who are dying need care in 4 areas: physical comfort, mental and emotional needs, spiritual needs, and practical tasks. Family of the dying person needs support well with practical tasks and emotional distress. So physical comfort is typically the big one. Most people, when I work with them direct service, when they're putting together their end of life documents like living wills and powers of attorney and things, they really are focusing on comfort care. So the living will document, which we'll go over later, really talks to strategies for the person to be comfortable in those end of life situations. I remember with my dad's late passing, very late in the process, he was getting some oral morphine squirted into his mouth because he wasn't able to really do the injections and things like that comfortably. So that's how they were managing his pain. Other people go on like a morphine drip, for example, for comfort late in life. Physical comfort can include strategies for managing pain, breathing problems, skin irritation, digestion, temperature sensitivity, and fatigue. One thing that they pointed out to me late in my dad's dying process was that his extremities got very cold. That's because the body's kind of pulling energy to the core. They support the core organs and things like that. So blankets and keeping them warm were a big deal at that point. Managing mental and emotional needs can include reassurance. Family members are there, caring for them with physical touch, soft lighting, relaxing music, and calming fragrances. So one thing we did with my mom, we put some quiet music on. We had some scents in the room that she was comfortable with from home. We would read books to her. With my dad, I found some, he was from Southern Italy, so I found some music that he would listen to growing up on YouTube. And so I would play that music for him sometime. And that, I actually saw him grin a little bit when we played that music for him, even though he wasn't really very responsive at that point. Spiritual needs may include finding meaning in one's life, ending disagreements with others, making peace with life circumstances. The dying person might find comfort in resolving unsettled issues with friends or family. Visits from a counselor or spiritual advisor may help. The example in my family was that we did an end of life ceremony with our local priest from the parish to come over. And it was amazing how my mom, even though she was mostly unconscious at that point, actually kind of responded to that, having the family members around the bed with her. She seemed to really be put at peace with that. So that was one thing that we did to kind of meet those spiritual needs. And practical tasks, maintaining personal hygiene for the dying person, household chores, paying bills, caring for pets, and so on. Okay, so now we'll talk about the differences, because I'm assuming most people have some understanding of hospice care and what it entails, but palliative care can get a little more confusing for folks. So palliative care aims to improve overall quality of life for the person suffering from the serious illness such as heart failure, COPD, dementia, or even cancer. In the palliative care modality, the person still receives treatment for their underlying condition. So this is a difference between palliative care and hospice care. So the example again, say cancer, the person's going through cancer treatment, it's excruciatingly painful. So the palliative care is designed to allow that person, while they're going through treatment, to feel more comfortable. The palliative team supports the person in other ways, including treating fatigue, weakness that develops from things like chemotherapy, or addressing anxiety and depression that a person might experience resulting from their illness. Palliative care is appropriate for anyone with a serious illness, whether it is chronic, curable, or life-threatening. So the palliative care is really the focus on comfort and reducing the breakthrough pain a person's experiencing in a situation where their illness or injury is causing a lot of pain. It does not require a terminal diagnosis. So again, that's a big difference between palliative care and hospice care. Hospice care provides comfort care, family support for someone with a terminal illness who usually has 6 months or less to live. So for the hospice care modality to start, the doctor has to have written an order that says hospice care, and he has to justify that by saying with the terminal illness or injury, the person has what they think is 6 months remaining to live. Key difference from palliative care, that the person does not receive curative treatment for their terminal condition anymore. So let's go back to that cancer example. Again, my wife's friend had lived at Ocean Shores. Her cancer had spread through her whole body. And so at that point, the doctor said, there's no further chemotherapy, radiation. There's nothing that's going to prevent this cancer from killing her ultimately. So then the situation became, from palliative care, it became then she decided to go off the treatment because it wasn't having any impact. It was causing her a lot of pain. And then she became a hospice care patient at that point because she decided she was no longer going to be treated for the terminal condition. So again, this is a big question that comes up that people wonder, what happens when I'm declared terminally ill with that 6 month timeline? It means whatever you're undergoing treatment for that terminal illness has to stop. Yes.
Is it the same people that provide this?
So maybe you have a good answer for that, Jen. Can be different teams, right?
Generally, no. Generally, there's a separate team for palliative care and hospice.
Are they the same agency?
Not necessarily. It may be, some agencies may be able to provide both depending on their staffing, but some may just strictly be hospice. And then palliative would originate from whoever, a lot of times whoever the original medical team was, primary care provider would order palliative care, whether it's within that own, like Kaiser, for example, I know has their own palliative care team. And so that's who would take over palliative care. Sometimes they work in conjunction with the primary care provider as well, or a hospital team if the person's in the hospital.
Yeah, great question, because in the example, again, with my wife's friend at Ocean Shores, undergoing the cancer treatment that was causing her so much pain, she was on the palliative care team there that were providing her with the medications like the morphine and things like that to manage that pain and discomfort, and doing other things to manage the nausea she was experiencing and things like that. They were kind of part of the cancer care team.
Yeah.
And then when she went on to hospice care because she had abandoned the cancer care treatment, then she had a hospice care agency that was then working with her at home. So kind of moved differently.
And that's what happened with my stepmom. She was diagnosed with metastatic cancer and it was terminal. But at that point, we were still sort of exploring what kind of treatment options there might be to prolong her life. But she was in a significant amount of pain. So she was hospitalized at Virginia Mason initially. We were working with the team there, but they brought in palliative in conjunction with exploring cancer treatments to manage her pain. And she was with palliative up until the third hospitalization, at which point we decided to transition her to hospice. And then palliative care backed away, and Providence actually came in and provided hospice for her. So
Yeah.
In the Virginia Mason Hospital?
we actually chose to have her discharged home on hospice, where she died 4 days later. Yeah.
That was an insurance.
Um,
That looks at the VA.
I don't have a lot of experience with the VA, but I do have contacts. So,
Because they have him on hospice.
yeah.
And they're kind of upset that he's still seeing his other doctors.
Yeah, that's unusual. That's an unusual use case.
Yeah, because typically, this is even the challenge sometimes you'll experience, like both my mom and dad were both in skilled nursing facilities when they ultimately passed. And again, the skilled nursing facility treatment team has their own doctors and nurses, and they're kind of trying to determine how to keep that person healthy in terms of going forward in life, where the hospice team is looking at how do we kind of dial down their life comfortably. And so there were a couple of occasions where they were calling me from the skilled nursing facility to say, well, if your dad has an infection, we're going to start antibiotics. And I was like, well, did you talk to the hospice care team? Because their view is that's not really an infection. Again, he's heating up because he's dying. You know, he's not fighting a fever. It's just the dying process. So sometimes you get stuck in the middle of who's making the proper treatment decision for end of life kind of thing. So my general rule was always to tell them, you need to talk with hospice care. Don't call me, call them. And then we would consult with hospice care. So unfortunately, those kind of conflicts do sometimes occur. So.
Okay, so you bring up a really pertinent situation with the skilled nursing facility. They are the doctors. I mean, you don't have, in their mindset, at least what we experienced, was they don't acknowledge other outside doctors. They're like, if you need a specialist, we will send you to that
Yeah.
specialist. And so if you don't have that, if in your dad's situation, was the hospice team like linked with a skilled nursing facility, or how did, because they don't
Yeah.
like to play well with
Oh,
others.
yeah, this is where it becomes difficult in skilled nursing, yeah, because it was Franciscan hospice care. It was not a Franciscan aligned skilled nursing facility. So we did have the doctor at the skilled nursing facility do the order for the hospice care.
Okay,
But the day-to-day activity, there was always, it seemed to be a little bit of conflict there because again, and rightfully so, the nurses had taken care of my mom and dad for months and they were just like, well, we have a view of how we're going to keep her going, when the view from the hospice care was like, there's no remaining to do here. We just need to keep her comfortable till she passes away.
right.
So like in the IV fluid situation, again, they started that IV fluid for my mom because she wasn't able to drink anymore. And understandably so, you know, they wanted to maintain hydration for her. But in talking with the hospice care services, they said, well, that's not really doing what they're hoping it will do.
Documents.
Yeah,
Don't do it.
exactly, yeah. And so then it became, we had to have the hospice services kind of intervene with them to say, the family and the living will says no artificial hydration, plus it's not doing anything.
Okay,
And
so
then,
it's just like stay involved.
Yeah, you really do
Communication
have to stay
going,
involved. Yeah.
confusion occurs.
Exactly.
And okay, all right.
It
I
does.
was just, so there's no real black and white. It's just.
Yeah.
Keep the communication going.
Yeah, and that's why I said family members really have to have some understanding of it because, and that example of my friend at Ocean Shores, the family members didn't quite have the understanding they really needed at times for it, so.
We don't do death very well in this culture. And so, you know, kind of what can happen is people are uncomfortable with death and with dying. And especially as Matt said, when they work in a facility where the goals of the facility are to rehab or to prolong life, there can be that conflict there. And it's hard for people to sometimes accept that death is imminent or that death is coming or that that's even the goal. I mean, I find that with my dad. My dad has chosen that he doesn't want treatments that are going to prolong his life. And he just had a small stroke a couple of weeks ago. And, you know, trying to communicate with the medical teams that are all about what can we do to prolong your life, that's not what he wants. He wants to maximize his quality of life for however much time he has left. And that's a hard concept for a lot of people to understand because we tend to be a culture of we're going to stay alive at all costs. So it can create kind of those challenging situations. And honestly, that's where really good, skilled hospice teams are worth their weight in gold because they can help family and individuals navigate those difficult conversations and help coach people through the process of accepting that death is coming. We're all going to die. And how do we want to maximize quality of life until that happens?
Yeah, like for example, that hydration question with my mom. I had family members that were very unhappy with that because they were saying, oh my gosh, she's gonna dry up like a prune, what a horrible way to die. And it's just like, well, that's not physiologically what's really going to happen, it's just part of the dying process. But having spoken with the hospice nurses a couple of different times, it allowed them to kind of come around and understand, okay, this is part of the letting go, that you don't continue to try to pump food and fluid into a body that isn't able to manage it any longer. So they were really useful in that regard to kind of give you the coaching of what needs to be done there. And this other handout I gave you guys, some important things to know about end-of-life care. It really does talk a little more in depth about things like we're talking about and how our understanding as a well person of what an experience of someone who's in that late stage of life is very different. So this is kind of helps to kind of normalize some of those things that can go on in those end of life situations. So I encourage you guys to keep this and read through it. That's important. So, okay, so hospice care has very specific eligibility. The person must be diagnosed as having 6 months or less to live and must no longer pursue curative care. Person may choose hospice because they are no longer receiving, I think it says, benefit from treatment, or they simply do not want to be treated any longer. So, so this is another thing that trips a lot of people up because it's the specific treatment related to that terminal illness or injury that the person's experiencing. So I've had people have a lot of concerns about this, saying, well, what if mom falls at home and she's bleeding? I mean, what do we do? Well, that's not related to her terminal condition. That's a new situation. So yeah, if mom were to fall at home and break her wrist or bleed out, then yeah, the hospice team would conduct an assessment there as to whether they can comfortably keep her safely at home and have her not experience pain from that illness or injury. So there are even situations where a person might need to go from a home setting to the hospital for a short period of time on hospice because they might have had some damaging illness or other injury that interfered, and at home they weren't able to keep them comfortable. So again, this is another kind of myth that's out there that, oh, I go on hospice, I'm going to be at home in a bed and I'm just going to die. Well, the goal is to keep you comfortable. You do stop the treatment of that terminal illness or injury, but you're still getting medical care. It's just being done in a different way. I don't know if I explained that very well.
That is a very pertinent example. No, that's a really good example because you have somebody that is, very in very poor condition, but if they fall, you're right. It's like, oh, we're not going to touch them. It's like, well, all it is a big gaping wound. Just stitch it up and
exactly. Or a broken bone, a significant broken bone. Well, you may not be able to treat that at home where the person's not going to be in an incredible amount of pain. So what do you do then? You still have to set the break or whatever.
Right.
So do you want to say anything on that?
Joe has a question. So
You work with the VA, right?
No, I don't. We have VA services in our office.
Okay, because I called you last week. And I
Okay.
think when you called back, you talked to my husband and I couldn't read what he wrote.
Oh, yeah, that's right. I was that veteran services, we did talk about that veteran services card was what I was trying to give you that information about that other program.
Because I wondered if they have palliative care because his urine was very cloudy and I asked that it be tested and the VA tested it. His heart doctor ordered it tested, but the hospice people were really upset and they said, why are you treating it? They were, and so this is really informative to me because he only went on hospice so that he could have better pain meds than Tylenol.
Yeah. Does it feel like that's not happening right now? Or,
Well, I feel like they're trying to pull the plug on it. I mean, they're upset that he gets any other treatment.
okay,
And, you know, like,
So like in this example, it would be like, maybe it's a possible urine infection, and so
Yeah.
you would want to get antibiotics for a urine infection, but still be on hospice.
he wasn't saying goodnight to the people. He's had rheumatoid arthritis for 45 years. He has a lot of disarticulated joints and stuff. And it's an inflammation, rheumatoid arthritis. And he's got some other stuff going on too. And he was in a lot of pain. And they just said, oh, they're so upset about addiction that all they give you is Tylenol under any circumstances at the VA.
wow,
And
that's,
they said, so you have to go
Yeah.
on hospice to do it. And then the hospice people came out here and said, no, we need a DNR. And he said, like hell I do. And so we're having all this, and the hospice people too are kind of,
is that an agency that's working under a veteran's doctor's order? The hospice was
Yeah,
ordered
it's
by the Providence?
Providence.
Okay, okay,
And it's called Providence Hospice.
okay.
It's in Seattle, and they.
Are you talking to like the social worker on the team, or who have you been in talks with, Because there's usually a social
The social
worker.
worker quit, and so somebody else came out
Okay.
last week. And he's only been on it a couple of weeks.
Okay, yeah, they should have a lead kind of social worker, usually is the one that's in contact with the family and answering questions and things like that, so.
But they're all about, they sat down there and they were going on about his funeral and everything, and he got really upset. They
Yeah.
had to pay for his funeral in advance, and we had to pick out the hymns, and he's not picking out any hymns.
Yeah, it does seem like it would be helpful to have somebody that can really explain the
Yeah.
different services to him and really try to understand what his goals and wishes are. Because that's really the fundamental, beacon for all of these is what is the individual's goals and wishes?
Exactly,
And
yeah.
if your husband is wanting to continue to live as long as he can, then hospice isn't really the appropriate
Yeah.
avenue for him.
Yeah.
Sounds like
Well, puzzled by that.
it would be
The palliative
better.
care, yeah.
That's the definition of palliative care,
Right.
chronic illness that needs additional management for pain or.
And I don't know what the VA is like with palliative care, but I do have some contacts, so I can reach out and
Yeah.
see if I can, we'll talk afterwards, Joe, and I'll get your husband's information.
Yeah,
and
and
see
please
if-
grab that veteran's card back there, because that was.
They
Yeah.
have these things, and I went in one time, and Life doesn't do it anymore, and then I went out to American Lake and I talked to a couple agencies, and they said it would take 2 months for them to do an intake, and it just,
Yeah, it's frustrating. And I wanted you to follow up with them too on that question we had on the aided attendant pension replacement into a care facility. I think that's what we talked about on the.
yeah,
first- Yeah,
no, they're paying for 44 hours a week at $45 an hour, but they won't apply a penny.
yeah.
Family.
I did talk to our veterans team that day, and that's why I called you back. And there's parallel kind of programs going on there. The one you're getting is home care that doesn't transfer dollars into care facility things. But there's that other pension you applied for, I believe, is the one that would fund that. So yeah, please call them and see if you can follow up and make sure that you're kind of squaring with their, yeah, great. Well, I'm sorry to recognize what we talked about.
No, that's fine.
I have a question.
Yes.
You mentioned a lead social worker, in hospice type care works with the family. Is there a similar type of organization or structure for the palliative care team?
Typically, if it's something where it's that intense and going in that direction, in the cancer care world, for example, like my wife, even when she had her breast cancer treatment, there was a social worker that was involved. So I would imagine in most palliative care situations, there is a social worker that's kind of working with the family to determine what other needs are being identified and other things, and gaps in services and things. We get a lot of referrals at our county office for that family caregiver support program for people on palliative care, because typically it's a husband or wife that's caring for that person and might need some relief. And typically those referrals come either from a nurse case manager or a social worker. Sometimes the two roles are kind of merged a little bit, but should either be like a nurse case manager, that's like a chronic illness case manager, or it would be the social worker on the palliative care team.
Yeah, they're very focused on whole person care. They're not just treating a disease or a condition, they're treating the whole person, and that includes a lot of other things.
In the palliative situation?
And even really hospice as well. That's why a social worker can be a really beneficial person on the team to just kind of help you through all those other aspects that you're dealing with.
I wanted to bring out the Medicare book for Medicare people that are on Medicare in hospice. So it's on pages 26 and 27 in the new book that came out this in October, all about hospice care and how it's administered and what it means and how it becomes part of the treatment program and all that, and what services can typically be available under hospice care and all those different things. So that's in here. Okay, so who provides the care and when? This is kind of going back to the questions you guys had. Palliative care provided by a team that's treating an illness, including a doctor specialized in palliative medicine, nurse, pharmacist, social worker, dietitian, chaplain, volunteers. And again, thinking of the cancer kind of situation that people can often be in, palliative care kind of is part of that, where you're getting all these supportive services and things like that. Hospice care also provided by a team may include hospice medical director, nurse case manager, social worker, bereavement counselor, home health aide, and hospice volunteers. So like Providence is the agency that's providing for your husband. And so their services are provided through the Providence network, and they should include some of these supportive things that are going on as well. Are you getting any kind of aid, home health aid, or are you getting that through the care hours?
I don't know.
Okay, okay, no problem.
There were two social workers there on the same day.
Okay, got it. Typically, they offer what's known as a bath aid on hospice care, where someone's coming in and can help with bathing.
Except they don't show up.
Well, that's not.
The social worker and the bather were both coming on Friday, and neither one of them called or showed up, so.
I'm sorry, that's really disappointing. I'm sorry about
Yes.
that. Most home health agencies also offer hospice care. So home health is the modality where you're doing some rehab at home, typically following an illness or an injury. Like when my dad fell in the yard, broke his ribs, when he returned home after treatment in the hospital, he had home health. And so they would come in and help him with his breathing, help him standing up, walking, moving, all kinds of different things. So that's home health. And then that same agency returned when he was on hospice care. It was Francisca when he was in hospice care in the facility. Most treatment providers for chronic life-threatening conditions can offer palliative care. Doctor's orders are required to start both palliative care and hospice care. So one thing I always remind families is, especially with the husbands, oftentimes they're not big on seeing doctors. And so they'll push back and say, well, I'm healthy, I don't need to see a doctor. Well, at some point, if an illness or injury develops suddenly, you're going to need doctor's orders, okay? And typically urgent care providers, emergency room doctors are not going to be a guy that's going to want to write orders. They're going to say, you need to talk to your physician's office, your family physician, whatever the case might be. So, and it's hard nowadays because doctors are retiring. I know like at Kaiser, where my wife and I are members, she's had 2 or 3 different oncologists over the last year that keep coming and going. So it does get frustrating, but you really need to stick it out and make sure there's someone in the community that can direct care for the person that's in your family. Because again, they might be healthy today and might have a serious illness or injury tomorrow. So does Medicare pay for palliative and hospice care? Yes, on Medicare Part B, as do most commercial insurances, TRICARE, Veterans Health Coverage, Medicaid pay for palliative care depending upon the treatment. Medicare really does not say separately that it's palliative care from the rest of the covered services. So a palliative care provider, the services are being paid like any doctor, because really, again, you're talking about active treatment. So whatever the treatment team is doing for a person's cancer, for example, under their Medicare coverage, it's going to be folded into those treatment services. Medicare A, most commercial insurance, TRICARE, Veterans Healthcare can pay for hospice care as well. More details on the following slide. So one thing we remind people in the Medicare world, the Medicare Advantage plans that a lot of people are on through United Healthcare, Cigna, Humana, whatever the case might be, hospice is still a service provided by Original Medicare. And the reason I bring this up is because we've had more than one client call us after they've been told they need to go on hospice care. They've talked to their Advantage plan only to be told we don't cover hospice care. It's covered even though the person's on an Advantage plan by Original Medicare. And why that is, I don't know, but that's the situation. So that can get confusing in the hospice world as well.
Okay, wait, I want to make sure that I captured that.
Yes.
Because we just switched from a supplement to an advantage.
Okay.
So you're saying that even if I call, if I panic and I'm like, do you guys cover it? They'll tell me no.
They will tell you no.
But it will, if the bills go through and they process it, we'll see that it's covered.
Yes, and all the providers involved should know they shouldn't bill the Advantage plan, that they bill Medicare and on.
Wait, how, I thought the only thing you carry around now with an Advantage plan is your Advantage card,
Exactly.
like my Aetna card.
This is why it gets so confusing, because the hospice services are gonna be billing original Medicare. Even though you were told when you went on the Advantage plan, that's who handles the bills and claims.
So do they
Yeah.
need to have their original Medicare card still?
They should, because the hospice care provider's likely going to ask for that, because they're not gonna be billing the Advantage plan.
Oh my God.
And they should help you figure all
But
that
they
out.
should,
You
again.
don't do anything. They don't even explain what an Advantage plan is.
So this box here
Oh
on
my
page,
God.
this box on page 27.
They should, I agree with you.
Original Medicare will be billed for your hospice care, even if you're in a Medicare Advantage plan. When you get hospice care, your Medicare Advantage plan will still cover services that aren't part of your terminal illness or conditions related to your terminal illness. So this is where it's gonna get confusing, because
Okay.
this person is still likely gonna have their assigned Advantage plan doctor for other things that might come up, illnesses or injuries that would be happening. But for the hospice care treatment and services, it's gonna be handled by bills and claims going out to original Medicare.
Okay, so hospice, so in this definition, or maybe it was the previous chart, your teams. Go back to the previous chart if you would, please.
That one, or
Oh. You said there were specific teams. There's teams of people that.
yeah, that's, yeah.
Nurse care manager, so hospice is a nurse care manager, social worker, bereavement counselor. So you're saying some of those people are gonna bill our Advantage plan, and then some of those people are gonna bill
No,
through Medicaid for
the
hospice.
hospice services itself, which are designed to provide end-of-life care, are going to be billing original Medicare. But whoever his family doctor is, whatever things are going on, if with family doctor visits and things, those are still gonna be billed under the Advantage plan. Now,
If they occur.
If they
They're
occur,
not,
if they occur.
typically, they don't occur.
exactly, they shouldn't be occurring much, because hospice is kind of managing everything at
And that
that point.
hospice team.
Yeah.
That's all in this
Is
list.
managing, yeah,
Is truly a Medicare.
exactly,
Paid.
exactly.
Okay, so you kind of almost transitioned from your Advantage plan over to Medicare.
That's one way of
when
looking
you
at
go
it,
into
exactly,
hospice.
exactly.
Typically,
Yeah.
unless like your husband's case, you've got different doctors that are still involved.
Now,
Got it.
I guess the example would be, so this person's still taking their blood pressure medication, they're still taking their cholesterol medication, you don't need to abandon those things.
Right?
Those would still be being prescribed by the family doctor. Hospice care is not going to provide prescriptions for routine medications.
Oh, okay. So
Yeah.
my mom has like a kidney doctor and a heart doctor, and they've got her on this cocktail of meds.
Yeah,
But then if she was to go into, have dementia or something and need, and like really decay or
Yeah.
have a stroke, that puts her in that, this isn't gonna lung. So she would still continue the kidney and the heart
yeah, if that,
cocktail.
yeah,
until-
potentially, yeah.
If it keeps her comfortable.
Yeah, exactly, yeah,
It's
potentially.
about comfort.
Yeah,
I mean,
about
because some
comfort.
people will elect to go off all medications,
Exactly.
because again, they're not trying to prolong their life at that point. But if it's a medication that provides comfort,
Right.
like, hypertensive crisis can be very uncomfortable. So if staying on a blood pressure medicine
Okay.
keeps their blood pressure from going sky high and thereby keeps them comfortable, then it may make sense to keep them on that blood pressure.
Okay, so it is kind of a scenario where she would continue this cocktail of things that have got her dialed in, and then be actually on hospice. The cocktail of drugs and that care team is still involved. They're Medicare Advantage. And then the hospice could actually work in conjunction and be part of a Medicare paid.
Exactly, yeah.
Wow, this is so fascinating, you guys.
Yeah,
Thank
it's-
you.
There's a lot of moving parts to it.
Now, we had a question online about the Medicare handbook.
Yeah.
Where can people get that?
We have more in our office. We
Okay.
have a couple hundred of them. So if people call our office, we put one in the mail out to them.
Okay,
They can order one through Medicare as well, 1-800 Medicare. It's a pretty useful book, actually. Most people get it and they don't really look at it, but I would encourage people to look through it, kind of determine what's in there that might be of use to them. Okay, so in this hospice care scenario for a person on Medicare, what does that look like? Co-payment of $5 for each prescription for outpatient drugs for pain and symptom management. So again, this is the assumption where the hospice care services are, the doctor is writing orders for things for pain medications and things like that. In the rare case, the hospice benefit doesn't cover your drug, the hospice provider should contact your plan to see if Part D covers it. So you're really entering that hospice world where they're managing all kinds of different things, including the prescriptions and pharmacy services and things like that. You may pay 5% of the Medicare approved amount for inpatient respite care. Copay can't exceed the inpatient hospital deductible a year. Original Medicare will still pay for covered benefits for any health problems that aren't part of your children or illness and related conditions, but this is unusual. Once you choose hospice care, like we're talking about, your hospice benefit will usually cover all you need. So again, this is where that dialogue should be happening with the hospice provider to say, okay, you know, mom's on these kidney medications, whatever the case might be, but kidney failure is kind of her terminal condition. And so would they say you would still want to be taking those medications or not? So then that's where the dialogue, they may say very well, with that being the terminal illness, we're not treating that anymore. So that's just an example I'm giving. So. Okay, a lot of stuff here. We won't go through every step of it, but it's more information that you can take home with you on Medicare payments for hospice care. Only your hospice doctor and your regular doctor, if you have one, can certify you're terminally ill and have a life expectancy of 6 months or less. After 6 months, you can continue to get hospice care as long as the hospice medical doctor, hospice doctor recertifies at a face-to-face meeting that you're still terminally ill. So once you go on hospice, is it's prescriptive, meaning whatever hospice care you're getting is going to result in you dying within 6 months? No. I mean, you could talk to all kinds of people who are going to say, like my mother-in-law, on hospice was off hospice, on hospice was off hospice. For 2 or 3 years that happened. So, so they may say whatever terminal decline she's having has plateaued, and like in my mother-in-law's case, and so they said, no reason for her to remain on hospice because she's no longer terminal. Now, she might have died the next day, right? I mean, she was 96 years old. So, but they're doing their very best to assess whatever terminal decline they're seeing, whether it's continuing or it might have plateaued in some way. Now, in her case, it was a mixture of kind of like congestive heart failure and other things. And so oftentimes there's like a variety of diagnoses that are kind of combined in a person that are all contributing to that terminal decline, but even the doctor may not be able to say what ultimately might be the cause of death. You know, it's not as scientific as we'd like it to be. So once she got stable again, in their estimation, then she didn't need to be on hospice any longer. She wasn't in a lot of pain or anything like that. So, but then she had another decline, and then it looked like she was in a terminal decline again. So she was back on hospice care again. So it can kind of fluctuate. It go on, off, and back on again. So it's.
So when you go off of hospice care, I mean, you've made some changes to the medications and situations, and and your mother-in-law plateaued. What got pulled away at that point? Then tell me.
Yeah. So basically, it reverted to kind of a palliative care model at that point, where she was still getting the same pain management and symptom management. But as illnesses and injuries developed, then she was back seeing her regular family doctor to kind of treat them.
Okay.
Because she was treatable again, I guess you'd say, for lack of a better way of describing it.
Okay.
Now, she was in a situation in the adult family home where she was mostly total care. She really wasn't very responsive.
Okay.
So they were just going based upon whether she was sleeping well, whether she expressed any pain or anything like that. So it was very artful versus scientific kind of determination of whether she was terminally ill or not. I've had other people be in more situations where, yeah, they went off cancer treatment and it looked like that cancer was going to spread in their body and it kind of didn't. And so then they're back off hospice, and maybe they would try some other cancer treatments at that point to see if it might, extend their life. So again, every situation is a little bit different. You were going to say something, Jen?
Well, and we've also seen people who are on a lot of different medications for a lot of different chronic medical problems. And when they go on hospice and they go off all those medications, they actually tend to get better in some ways. It's kind of paradoxical. And so like their health actually kind of improves overall. And so then, you know, that may result in them graduating from hospice. That can happen as well, where they just are better and they're no longer in this terminal state of dying. And so they go off hospice. And as Matt said, then they may end up back on it again, but it can be a little bit of a roller coaster.
So I'm kind of envisioning a coordination, billing nightmare. Does the hospice team kind of say, okay, tapping out over to you guys, and then
Yeah,
you
typically.
get these bills, and then you've got to have it.
Yeah, typically I know with my mother-in-law, it was all part of Kaiser, so it was a little bit easier because they're very tightly controlled within their own provider networks.
Okay,
But yeah, you potentially, could have that situation where the hospice team was billing original Medicare and then Medicare Advantage is billing for the other doctor services. And things. So yeah, it will get confusing, I'm sure, in those situations. And so just try to understand how the modality works. Hospice care is original Medicare billing, regular treatment and services are billing out to the Advantage plan. So, and again, they should know in their world that that's the rule. They should know that and bill accordingly. So it's not pushing back on you denials and things like that.
Okay.
So, okay, so just to use the Medicare as the model for hospice, Medicare is not going to cover these things once your hospice benefits start. So we can even look at this and say, okay, what does hospice mean to us in terms of understanding it? So treatment intended to cure your terminal illness and or related conditions. So that's not part of the hospice care package. That should have ended when you went on hospice care. So talk with your doctor if you're thinking about getting treatment to cure your illness. As a hospice patient, you always have the right to stop hospice care at any time. So you're not locked in, you're not stuck with it, you can change it. And as far as the doctors view it, yes, it can change as well. You could go on it and then go off it as well. Or you could decide, you know, I thought differently about this. I've heard about some new experimental cancer treatment that's being offered here at Seattle or something. I want to try that. And so a person may say, okay, I'm off hospice and I want to try something different, or the family may say that. And then you're off hospice and you're back in the treatment world where that terminal illness that's been identified could be treated again.
how do they declare you're off hospice? Do you coordinate that with your hospice team and then say, we want to discontinue hospice service on this day?
Yeah, basically, they would be the ones that is giving you that end date, so the treatments provided by the regular family doctor can take it back over again.
Okay, and then it said related conditions. So mom's cocktail, we'll use my mom as an example. Mom's cocktail of kidney medicines and heart medicines, and then she gets cancer that gives her a terminal diagnosis. So as I think we talked about it earlier, you said she could continue her kidney and heart doctor stuff and then still be not treated for cancer and on hospice.
Yeah, and so it's
Okay.
kind of focusing on what that terminal condition is and what situations are kind of spinning off from that, in my view. I don't know how you look at that, Jen, but that's kind of my view of it.
That's interesting because they told me that when Gary went on Medicare that they would, the hospice came out and said that they were going to take him off his heart medication, his blood pressure medication, his prostate medication. They're going to take all that stuff away from him. And I called the VA and they said regular Medicare is that way, but the VA, as they treat him separately for those things and the hospice doesn't. See, I don't think you should be on hospice.
Okay, well, then, yeah, you're free to terminate it
No,
too,
but I mean, but that's what they said. They said
Yeah.
you can't do anything except palliative care. Once you go on hospice, you don't have any of that. And they were really upset that I wanted him tested and he did have a bladder infection, a UTI.
Yeah.
And they said, no, we shouldn't, and they were.
Oh, interesting.
Yeah, that's surprising to me because those are going to spin off symptoms that are going to be uncomfortable for him.
Oh, yeah.
So I would see that's something you would manage. Because it's not,
He started having this congestive heart failure and his heart rate would go way up, and it was like almost like panic attack. And so they put one of those monitors on him.
Sure.
And there was in a week, there were 5 times that it lasted over half an hour. I mean, he was, but it would sometimes just be for a few minutes, but it was very uncomfortable for him.
To your point, that there's some things that are very uncomfortable that can be managed while you're on hospice.
Yeah, I mean, that said, like, my dad's doctor told us last week that, they actually call things like UTIs and pneumonias an old man's best friend, because for somebody that is not wanting to prolong their life, it may be that getting a urinary tract infection or pneumonia and not treating it is a way to bring about the end of your life,
Gotcha, yeah,
right?
yeah.
So it's kind of an
Yeah,
intentional choice of, I'm not trying to live forever. Like, I want nature to take its course. And so some people may choose, I'm not going to go on antibiotics if I get a UTI or pneumonia, because I'm done. I'm ready,
Done.
right?
Yeah.
Right? I'm okay with dying.
Wow.
So it really is, this is what
Yeah.
Matt says, it's an art, not a science, and that art is going to be influenced by the people on the team too, and how they, like I said, a good hospice team is worth their weight in gold because they can help you through those conversations. These are tough choices.
This is really good feedback though, for when I do these, because I may need to dive into it a little bit more with some of the colleagues that I know that work in hospice care and say, these questions are coming up, and what's kind of the current understanding and the current philosophy behind what you guys are doing there. Because maybe it's not as expansive as I'm kind of thinking it might be. Maybe it's a little stricter than it is.
The hospice environment has changed a lot too, just from my perspective, having been in pre-hospital medicine and 911 systems for 23 years. It used to be that in this area, hospice was really just covered by Franciscan and Multicare, and Kaiser had their own. Now, a lot of the home care companies are getting into providing hospice because there's a financial benefit to them to do that. But it's kind of changed the environment of kind of the theories and the approach to hospice, if you know what I mean. Like, you've gone from having a couple of agencies that's all they do is hospice. And so they really specialize in it, and they're well versed in that dance, that art of providing care to the families, to now you've got a lot of different agencies that are doing it.
Yeah.
They don't necessarily always have the nuance to be able to
Yeah, they're just not
dance this
practiced
dance.
at it.
You know what I mean? Yes. If that makes sense.
These people that are coming in 44 hours a week, it's senior helpers, and they had, the gift bags and all this stuff. And somebody came out and they spent 2 hours signing them up and all this business. And I said, who owns this? And they told me, and I said, well, her. And they said, well, no, she actually has a whole chain of gas stations and we never see her.
Mm.
And I thought, and I mean,
They
all kinds of weird people, and some can't speak English, and they don't know anything about medicine. They're just senior helpers, and
Well,
they should know what
caregivers
they're not
don't
supposed to do.
necessarily, I mean, and that's, caregiving agencies are all kind of a little bit different. Some caregivers are what's called nurse delegated, meaning they're working under a nurse's license, and so they're able to give medications and things like that. Some have had more training than others, like a certified nursing assistant is going to go through a 70-hour state program to be certified, versus a home care worker that's kind of helping with bathing and dressing and toileting and cleaning up the home and helping fix meals, might not have gone through all that training. So there's kind of a spectrum there. I do have some sheets that have a list of home care agencies that we know we've had good experience with. I'm happy to give you that list as well.
Well, the VA is the one that does it,
Right.
so I don't think I have anything. But these are mostly African refugees.
Yeah, and that is kind of it is a specialty that a lot of people from other countries, work in, and in many cases provide very good care.
I guess I wondered about how good the background checks were, because they haven't been here very long. language barriers.
Yeah, I mean,
You know?
typically, if you have an agency that's providing that type of care, everybody does have to be background checked. But it's, yeah, how historical is it? I understand. No, I understand. It's probably not all that
She
historical.
came here when she was 19 or something.
Yeah,
and she'd been-
they do have to do the fundamentals of caregiving. And we do have a shortage of people willing to work in those care agencies all over the place, not only for home care, but for facility care as well. So yeah, it's certain cultures, they're willing to do that work and they're comfortable doing it. Some other cultures, not so much. So, but you're right, in terms of the healthcare world, you've seen it here locally. Places in Tacoma that were lifelong locally owned care facilities and things have been bought out by these big healthcare conglomerates. Sometimes they're not even healthcare conglomerates, they're just investment banking firms. And so they don't want to chain of movie theaters over here and they don't want to chain of skilled nursing facilities over there. So a lot of that's going on. So you're going to see a lot of places that might have been for years locally owned that are now owned from some entity that's nowhere near local. It could be back east somewhere for all that matters.
So I have a question about the hospice agencies, because they seem to be, hospice kind of seems to be separate from the Medicare Advantage. Like if I go to, I normally would find an ombudsman with like my healthcare. So I'd call Aetna and, you know, we're going on hospice. Do you have an agency that you recommend? You know, I'd like to interview them and talk, because I think you're telling me that there's such a spectrum out there. And you're saying one thing and you're experiencing something very different. And so I'd like to just, you know, if at that time I'll talk to them. And so is there, and Aetna's probably going to say, we don't do hospice. We don't cover it. Over to you. You guys figure it out. So is there an ombudsman or somebody who can help me navigate these conversations where they're saying, no, your mom has to go off of her heart medication. And I'm going, no, I want you to be, I want her to be on hospice for cancer and still be on her heart medication.
Well, you know, we're kind of in Pierce County, at least, we have Multicare, Franciscan, Kaiser, Community Healthcare, and that's pretty much it. So they're all going to have agencies within their service provider network that do home health and hospice. And then there's some independent ones as well.
But now if I'm Aetna, I mean, so she's in an assisted living facility in Puyallup in Pierce County.
Okay.
So if it's decided that she needs to go on hospice, so what I'm hearing is that Medicare will just provide a hospice agency and it's going to be Kaiser Multicare or something like that. Is that what I'm hearing?
The order is still going to need to come from whoever her current treating physician is. They're going to need to order it.
Okay.
So yeah, so
Who
typically,
do they order? I've also found, who do they order it to?
well, typically they're going to order for whoever they're aligned with or adjacent to as a provider. So if they're linked to Franciscan or they're contracted with, they're probably going to send it an order to Franciscan Home Health and Hospice. If they're multi-care linked, they're probably going to send it. Or they might have another affiliate that they send folks to, like Puget Sound Home Health and Hospice and Vision Home Care and Home Health and Hospice. So there's a few independent ones around and there's a few other ones around.
And they might give you choices. Like
Yeah.
we had a retired assistant chief that was dying of cancer that lived in Bonnie Lake, and he was at St. Francis. And when they discharged him home, they discharged him on hospice, and they basically gave the family, well, they had 3 different hospice agencies that the person in the hospital worked with. And unfortunately, the hospice agency that picked it up must not have realized that he was in the Lake Taps, Bonnie Lake area, and they don't actually provide hospice down here. So there was unfortunately a little bit of a delay in that care. But you can go to any hospice care provider you want to that provides hospice in the area. You could call them. So like, you know, and the VA might be a little bit different. I'm not 100% sure about with the VA, but like with his hospice, I was able to connect him to a different hospice care provider that I had good experiences with, and they were able to just transfer his hospice from this agency that doesn't actually even provide it in Pierce County to this other hospice care provider.
Okay, so kind of word of mouth or just they'll get a referral, but don't feel locked into that referral. We could maneuver into a different one.
Exactly, yeah.
Okay.
Yeah, there's like I said, there's aligned ones with the networks. There's also independent home health and hospice providers out there too. So that you would definitely have the ability to have a choice there.
Are they linked with any kind of a brokerage company? Like there are a place for mom, or there's some things that do living situation,
Yeah,
referrals.
for
Is there
home
a
care
hospice referral agencies?
You might try K-Care. They're
Okay,
pretty
down
good.
in Puyallup.
Yeah, they're pretty good at knowing what local available service providers are. And Lisa Doyle, the founder, is a nurse, so I'm guessing they would.
About that.
I have a number of different agencies too, in addition to K-Care, that I can give you their brochures and you can reach out to them.
Okay, and so just like they would do living situations, they do hospice.
Yeah,
Hospice
exactly.
services or other.
Yeah, they
Okay,
should,
great.
like Jen was saying, the geographical coverage thing would be a big question there.
Yeah, interestingly enough, in the yellow book, hospice only has two agencies
Okay.
listed under it, Franciscan and multi-care,
That's what I
which are
figured.
the
That's
two
Big ones,
kind of big ones and the ones that have been doing it for a long time.
but they're not by any means the only ones.
No.
They're not the only one.
Ah, okay, so if I do have a problem with this and I find that they're not doing something that I want, do I go back to the primary care physician and have them help me fight? Who's the?
So you
who's
would
the one
want
who
to
can
change,
help
you would
conversations?
want to, you would say you wanted to abandon that possibility and go to a different hospice provider? Is that
Oh,
kind
no,
of
I'm
what you're
thinking just
thinking?
with, we're established with a hospice provider and then we have an argument, we have a disagreement, not argument,
Yeah.
just a different viewpoint of what should be provided with under that hospice umbrella.
They
Is
should
there-
have their own internal oversight. There should be someone within the hospice service that you could address with your issues. I would
Okay.
hope, because that's the whole point of having an agency, is that there's layers there.
Okay,
So they should have somebody there or some outside, quality assurance kind of entity that helps out. I apologize, I don't know who that would be,
but nothing at the Pierce County level.
because Ombudsman Services at our office does care facility kind of dispute resolution, doesn't really go into
That's
the.
the sign I've seen in my mom's
Yeah,
assisted
yeah,
living
yeah,
facility.
yeah,
That's why I was wondering.
Yeah, that's a good question, but we
Okay.
don't do the oversight on that.
All right, thanks.
Yeah, no, these are all.
Sorry to
No, these are wonderful questions. And like I said, I'll see if I can research a little bit more this first bullet point, because I think that's where we're all feeling a little confusion. Treatment intended to cure your terminal illness and or related conditions. I guess the related conditions question is the one we're kind of grappling with a little bit here and wondering what that means. Because in my view, it shouldn't mean other things that were pre-existing prior to the terminal illness or injury developing, like high cholesterol, blood pressure, and things. But the other view would be, well, why would you be treating any of that if you're terminally ill? So that's where I want to get a little bit more clarity for you guys.
Yes.
Yes.
Thank you.
Yeah. Again, they're not going to provide any kind of payment for prescription drugs to cure your illness other than for symptom control and pain relief. Because again, you're in the hospice world where you're not treating the terminal illness any longer. So you're not going to be on cancer medications or if it's a kidney, they're not going to have kidney dialysis going on if kidney failure is what is your terminal condition. So, and then care you get as a hospital outpatient, like in an emergency room, unless arranged by your hospice team. And again, this is why when you go on hospice, they typically make sure that you have the hospice number available close by all over your house or apartment, because they want to remind you not to call 911 in an emergency, to call the hospice team to direct your care, because you're supposed to be getting care coordinated by the hospice team. Back in the day when people still had home phones, when I was working, they would tape an actual bright orange sticker on there saying, do not call 911, call hospice 24 hours a day. So again, this is because you're in the hospice world and emergencies need to be kind of defined by them as to who's treating that emergency if it might occur.
So if a person falls and has a gaping wound or something, call
Yeah,
your
they would still
hospice
want,
team?
yeah, they'd still want you to call them first, let them know what happened, and that you're then getting emergency care for them.
Okay, and then the conversation is much more methodical and much less.
Yeah. What's your experience on these?
Yeah, I mean, sometimes people will call 911. We've responded to scenes before where something's happened. Families instinctively called 911. And once we find out that they're on hospice, we will often then we'll ask for the hospice contact that they've been given. We'll contact hospice and then make those decisions collectively at scene.
We proceed and then sometimes you'll arrive and then maybe back off.
Yeah.
Okay.
Yeah, because again, like there's kind of this misnomer out there that somebody can't go to the hospital if they're on hospice, or their hospice will revoke. And that's not necessarily the case.
Or you meant that they pay.
They may go, if somebody falls and breaks their arm, it may be appropriate for them to go to the hospital, to the emergency department, maybe even get an x-ray, get that set, get medication, separate medication for pain, whatever that looks like. And if it's for a condition that they're not on hospice for, it won't revoke, right? And even if it is an exacerbation of the condition that they are on hospice for, let's say they're on hospice for congestive heart failure, and the person has a congestive heart failure exacerbation, they can't breathe, it's scary, you know, they do want to go to the emergency department and get treatment in that moment. Hospice may
Oxygen
revoke,
or something like that.
but once they're discharged from the hospital back home, they can go right back on hospice. So
It has to be a transition. You're off and then you're back on.
You can. Mhm.
Oh, interesting. And then is Medicare the people that you work with and they say, no, that doesn't sound right?
So again, the hospice care provider, the hospice care team should be guiding you through all of that. And I've been involved in situations like that where, you know, I was helping a person in our district that had some long-term chronic problems. He was on hospice. He wanted to go to the hospital for the condition that he was on hospice for, because he wanted to receive treatment. And I worked with the hospice team and they were going to guide the family through that process.
Oh, okay. Oh.
Okay, so I want to make sure people are aware of what WA Cares is. We have a flyer on it. This is the Washington State Long-Term Care Trust Act. It was on the ballot in November for people wanting to make it optional payroll deduction. It's mandatory right now for people that are actively working in the active workforce. So if that's you or a friend or family member, what it's going to mean is there's a payroll deduction happening. And if you work a certain number of years, pay into it, and then you become ill or injured and need care at home, some sort of support, or even care in a facility, it's going to be a fund that's going to provide you with $36,500 to pay for your care. So if you're actively working, this is relevant to your situation. If you're not, you're already retired or you're disabled on Social Security disability, this is not going to impact you, but we want to make sure people are aware that it is out there. And this is all designed to provide people with some level of fund to pay for their care so they don't have to spend their own money or they don't have to go on Medicaid. So if you hear about WA Cares, you're going to hear more about it here in the next few years when the benefit actually starts, which is July of 2026. So, but I always want to point this out to people in the active work world. It's something you want to be aware of. In the retirement world, you don't need to be aware of it, but there's scammers out there trying to prey on seniors to say, you have this benefit, you just have to give us your Social Security number and we'll set it all up for you. So please, it's only relevant if you're actively working. It's a mandatory payroll deduction. You're not having to take any action for it. But if you're out of the workaday world, this is not going to affect you at all. So. Okay, so legal documents, what you should have in place for palliative and or hospice care prior to the illness or injury happening. So you want to have durable financial and healthcare power of attorney forms signed and notarized before the care is needed. And I do have on the table some flyers for the dementia legal planning project. Anyone with a dementia diagnosis or 60 and over can get free legal help to set up powers of attorney and living wills. Post form you want to have, or also known as a DNR form, signed by the physician. A physician has to be the one that puts those signatures on those post or DNR forms. And especially for people that are on hospice, important to have these. So person isn't given CPR or some sort of some artificial resuscitation when they're already terminally ill.
How often do those have to be updated, or what is your recommendations there?
On the posts and DNRs,
Mm-hmm.
you know how frequently you guys want those updated? Have you seen them? Yeah.
Mostly when anything changes.
I've heard people that say, you know, the provable power of financial and healthcare powers of attorney, that they update those every couple of years. That's sometimes not practical because, like my parents' situation, we got it done before they became ill or injured, and then they lived a few years past that. So under the law, the person who signs that document with the notary stamping it has to be aware of what the document is saying what the details of it are. And once they became ill and injured, there was no way for them to understand those documents anymore. So what we had is what we had. Last will and testament, signed, notarized, witnessed, or witnessed, death certificates will be needed to settle accounts. And in my view, you want to make sure you and other trusted family members and professionals, such as the doctor's office, the family attorney's office, if you've got one, have copies of these forms and keep the originals in a known secure place. We have lots of families that will call us and say, Mom had a stroke. I think we did a power of attorney form. We can't find it. No good if you can't find it. So you want to, in my view, have these done early with trusted family members, and then just put them in a cabinet where everybody knows where they are, even mark that cabinet, and you only take them out when that illness or injury starts to take over that person's life. Prior to that point, you might not even need those documents, but you get them when the illness or injury's already happened. You have to have it happen before that. And the same with the last will and testament. My neighbor across the street, he fell in his bathroom, died. I think he was on the floor for 3 days because his other friend who was going to check on him was out of town that weekend. And he was a notorious collector of all the documents he had ever come across his hands his whole life. And so his brother, over a period of a month, cleaning out all the documents, finally found the will. But yeah, it would have saved him a lot of trouble if the will had been in a clear, visible place and he knew about it. So
Our wills are quite old, but when we had them made, what I did is got cards from the attorney and gave them to the children.
great,
And the kids have got them, and he's got a copy, so.
perfect.
If ours were gone, it wouldn't matter.
That's fantastic.
Stuff.
That is great.
And then they can't actually read them.
Yeah. I mean, that's great. And again, going back to my wife's friend in Ocean Shores, my wife for the last year, because she was terminally ill with cancer, her friend saying, you got to put the will together, you got to put the will together. Oh, no, my daughter will take care of it. Well, she died and now the daughter's in a big mess because doesn't have access to any of the bank accounts, doesn't have access to the utility accounts. There's arrears on the property taxes. And so she's scrambling to figure all this out because understandably, sometimes when people are terminally ill, they get very depressed and are like, who cares? I'm going to be dead anyway. Well, you're leaving a big mess behind for the people that care about you. So early planning, getting these documents done ahead of time, long before they're needed is really
Ours was
needed.
done like 20-some years ago, and my daughter was working at Warehouser, and there was a guy and we have tree farms, so there was a guy that knew all about trees. And so I just didn't think it was gonna work because we had rentals and then we were gonna sell them, and he had a collector car and all. And this attorney was so good. He put all the important things down, like who was gonna inherit.
Mhm.
And then he referred to an addendum. And someone told me years ago to look at your will on New Year's Day. It's better than making resolutions.
Ah, very good.
And so
Nice.
every New Year's Day, it's kind of,
Yeah.
we get them out.
Yeah.
And the will refers to that, which puts an honor on it.
Yeah.
The attorney doesn't have a copy of it, but it's in there.
Yeah, yeah.
And so I'm having trouble with my husband right now. He doesn't want to do that anymore. He hasn't done it for a couple of years. But
So the addendum is not
little things
notarized
like
or?
jewelry and guns and, that kind
Oh,
of.
yes,
stuff.
yes.
You know,
That it's
because
tangible
things
assets.
change,
Yeah.
Right.
And so, and it was, I thought we had a very complicated estate, and he just made it so easy. It wasn't his first rodeo,
Yeah.
And I was really, for somebody that specializes in estate planning,
Mhm.
they really know what they're doing.
They do. The one thing I'll throw out there that I think can happen sometimes is particularly in couple situations, their power of attorney and healthcare power of attorney might just be each other. But if something were to happen to that other person, then there's kind of nobody. So like in your situation,
I think.
God forbid, Joe, something happened to you, and your husband, now somebody needs to be power of attorney for him. If there's a secondary, that person should have a copy of that paperwork, not necessarily the
Oh.
will, but the power of
The
attorney.
attorney does.
Okay,
He's got all that stuff.
And your children are named on the power of attorney?
I believe so.
Yeah.
I will check today.
Yeah. it might be
But
helpful
I'll
for
tell you
them to
something.
have a
I'll
copy
tell you
of the
something else
power of
that's-
attorney
I
form
don't
too.
know if this applies to you or not, but my husband was in a minor accident and he just didn't put his brake on and was gonna go right through this building if it didn't have a big post there. And he's still on the insurance. This was in January. And I told the car, went out, bought another one, newer, but just like it, so his friends didn't know. Yeah. And, oh, I know, if you go to the Washington State Patrol for a test and you flunk it, they take your license.
Yeah.
But the VA has a place and you can go take the test and they won't turn it in. So we went up there and his glasses weren't good enough. She said, you can't pass the test with your glasses. Oh, well, he was, blue or red light in the simulator and all that kind of stuff. So he said, I'm gonna get new glasses. And he's made 2 appointments that he never keeps, kind of thing. But I said, it's okay, honey, you've got a chauffeur. I mean, I don't work, so, fine. And she looked at me, this was really bad. She said, what's gonna happen? You can't drive. And I went,
Yeah.
And that's what I'm saying. A lot of times we don't
8
think.
acres, and the houses, our friends that our kids grew up with, they've sold, and there's younger people that, these aren't my friends have died, They've moved to Spokane and they've moved to California and it's a big panic thing that I'm trying to deal with right now. And part of this whole planning thing, nobody ever says that.
Right. Matt actually brings that up in the caring for the caregiver, which was our last session, where unfortunately a lot of times it's startling the statistics around something happening to the caregiver before something happens to the person that's receiving care.
Yep. They have heart attacks. One of them got a brain tumor and was dead in 3 months. The other one had a massive heart attack. The caregivers too.
Yeah, the statistics are pretty dire, depending on what study you see, anywhere from 30 to 70% of the time of that over 60 husband and wife caregiver situation, it's the caregiver dies before the care receiver dies.
Well, we're in our 80s.
Yeah.
I was out putting the garden to bed yesterday. And I thought, I'd always thought I would downsize, but I don't know how much yard I'm gonna be able to take care of in 5 years, This has been a really wake up for me too. So,
Yeah, and it's a struggle. No one does it perfectly. We all think there's a perfect plan to do it, and there's not. So do you do the best you can in conversation with family members that you trust? One thing I always want to point out here on the first 2 bullet points, the financial and healthcare power of attorney documents can include the living will. Typically it's separate. And that's bullet point number 2, advanced directive for healthcare, also known as a living will. So basically the power of attorney forms are designating a decision maker for you in the event that you become ill or injured and you can't make medical and financial decisions for yourself. The living will basically provides an end of life script for that power of attorney to follow. So again, like in my mom's dad's situation, they had already done a living will notarized with us that said, in an end of life situation, I don't want to be kept alive with artificial hydration, nutrition, whatever. I just want to be kept comfortable. So again, this is really useful because it takes away some of that judgment from the power of attorney, because without the living will, you're imposing a lot of judgment upon yourself in those end of life situations. And as we're talking about, they're not as clear cut as we'd like them to be, right? So the living will is basically that person kind of telling you ahead of time, when it comes time for you to make the decisions, here is your guide for how those decisions can be made along with my wishes and how I want them to occur. So
I'm so glad you brought that up. Number 2 bullet, number 3 bullet conflict for my mom right now.
okay.
So what do we do? Do
How do
I?
they conflict? Can you be more specific about that?
It's the in the living will, she has a much more I don't want life supporting measure, excessive life supporting measures. And then in her post, as she's getting much older and much more uncomfortable with life and everything in general, is much more panicky. Of course, I want to be kept alive at all cost. And we're kind of like, okay, wait, now what? Okay, so yes, you signed the green form and you filled it out. We're going to resuscitate you and all of this, but we've got a living will over here that says not quite the same.
Yeah, those are tough situations to
Yeah.
navigate. The pulsed form is actually a medical order. It tends to be more for us, for first responders, for
Yes,
us.
it's green, it's on the
Hospital.
refrigerator. Yep.
And so,
Okay.
you know, if her pulse right now says, like if her heart stops
Mhm.
and her pulse right now says, I want full resuscitation, theoretically, we should be doing full resuscitation.
Okay,
Now-
now, it's right, and it's quick, and it's a checkbox, and
Yep.
you guys, it's very, very fast, very response focused.
Yep.
Not somebody in the hospital over the dying
That's gonna be
person, like,
more
let's
for
look at
someone
page
at the
10.
hospital. We
And-
don't tend to look at living wills. We just
Okay.
don't generally have the time in the situation.
Okay.
That's really more for those treatment considerations once they're in the hospital.
So what's-
Now,
we're
we
gonna
will
kick it down the
generally
road.
take the pulse with us. So let's just say that we did respond, we resuscitated her, got her heart, you know, going again. We would take the pulse with us to the hospital, and the hospital would refer to it initially, certainly while she's in the emergency department and still receiving emergent treatment.
Yep.
But then they're really gonna look more towards the living will for making those further decisions if she's not able to communicate that for herself.
Right, and especially if a family member brings it out and says, oops, we gotta follow this. Now we've got different decisions
Yeah.
to make as this progresses. Okay, all right, that's because that's where I was like, oh.
It's a
boy.
good, yeah, it's a good question. An example I give was like with my uncle who was on and off, pretty significant cancer treatments, and he was unconscious for like a week at a time every 3 months for these cancer treatments, which appeared to kind of plateau his leukemia. So he had a DNR form that said, yeah, I want to be resuscitated because he was in a stable, ill condition. The living will that we had said, should he be in a terminal condition and unable to voice his needs, that I would be the decision maker, and included on that is he wouldn't want to be resuscitated nor given artificial hydration or nutrition. So he got very sick then, ended up in the hospital with a colon blockage. And so in the emergency room, the doctor said, well, he's gone from a ill situation to a terminally ill situation. If we operate on him, it's probably going to kill him. But if that's what you want, and I said, no, we were able to get him over to Franciscan Hospice House the last 3 days. He was there unconscious, just on a morphine drip. So that situation kind of changed from kind of a DNR situation where he was like, I'm stable, I want to be kept alive, to me having to decide based upon what he told me, let's not keep him alive. He's terminally ill now. We don't want to do surgery on him. So that's kind of how I make the distinction. You know, your mom's still alive and making her own statements about what she wants to have
Yes.
happen.
Yes.
If that should change, then the script is telling you in that end of life situation, you're going to be voicing, you know what I'm saying? Does that kind of help at all?
Yeah, it does.
Yeah.
It does. And that's kind of what my gut was telling me, but I just wanted to, I can't be the only family that has a disagreement.
It comes up a lot.
No.
It comes up a
You're
lot.
not.
It
And
comes
I
up.
mean, we
Okay.
have been on calls where somebody has a pulse that says, do not resuscitate, their heart has stopped, and we have a family member that's saying, do everything you can to save them. And oftentimes we'll try and have just those gentle conversations of, this person's wishes, your loved one's wishes were that they don't want to have us go through all of this. And, you know, I mean, at the end of the day, if they are insisting that we do it, we do it, but
Do
we
it.
try and really have that conversation.
Even though they have that, I thought that was legally binding.
No, it's not. It can be changed, even by the individual, right?
Yep.
And the other thing too, again, we don't do death
We
very
don't do
well
well
in this
I
culture.
think you mentioned that
And
before.
when those pulse forms are being, I mean, I've sat in and I've heard with my own family members where a physician doesn't make it very clear what that top portion refers to. If your heart has stopped, if your body has died, natural death has already happened, right? You have died. Do you want us to try to reverse that? Right? And a lot of times people just think, they don't really think about really what CPR is. They just hear, do you want CPR or not? And of course, everybody's going to be like, no, I want to live, do CPR. They're not thinking about the fact that your body's actually died. Death has occurred. Do you want us to try and reverse that? And all that that entails, you know, potentially shocking your heart, giving you medications to restart the heart, putting a tube down your throat. If a lot of times I think if people were explained that this is really what CPR is, Do you want that if you have already died?
Watch a video.
Violating the body.
Yeah. So, you know, again, I think all of that kind of has to be taken in with some context to these documents. They don't just, they're not black and white
Yeah,
situations.
it's always a challenge too. And in my experience, again, the living will was very useful in those situations where my uncle, like I said, he was unconscious and very sick. My mom was unconscious and very sick, my dad. And so it really helped to have something that I could share with other family members and say, well, no, we had already done this years ago, mom and dad, and this is what they told me. And this is what they wanted to have happen. I'm going to make sure that their wishes are carried through, you know, so. But yeah, the post form, yeah, that's a different kind of situation. Again, if a person's already able to be in a stable situation, they're alive, they're saying, I want to be resuscitated, then yeah, you could definitely have many situations where the DNR is saying one thing and the living will is saying another, because in my family's situation, they were really, it was an anticipation of an end time when they're already very ill, unconscious, and not being able to voice what they want to have happen. And so I'm kind of directing their care. Versus years before that, yeah, I would wanted them to stay alive too with resuscitation potentially. So it's a challenge. It's a challenge. And you know, they want most nowadays when you go in to see doctors, they're always going to ask for these, especially if you go into hospital care, they're going to want these because they want to make sure if that person goes unconscious, someone that they can rely upon is directing the care and saying yes. Because like with my uncle, he went in for knee surgery. Knee surgery went fine. We brought him home. Doctor called literally when I was just walking through the door with him at home saying, he needs to come back here. He's dying. His kidneys are failing. It looks like he has leukemia. So we rushed him back to the hospital. They put him unconscious. So we went from a situation where we had the forms, thank goodness, where I thought we didn't need them to, oh my gosh, I'm having to give them orders. Yeah, give them the protectant medications, give him the blood transfusion, do whatever you can to keep him alive, because he wasn't, in my view, terminally ill at that point. But a few months later, he was. So yeah, I'm not going to do surgery on him when he's terminally ill and he's close to dying. You know what I mean? So, all right, and then
Situations.
yeah.
Yeah.
Yeah, and there were many times when my dad was falling and broke his arm and had little micro strokes and couldn't walk anymore. And it was just like, we go into a skilled nursing facility and they're like, okay, we're gonna do this. I'm like, DNR,
Yeah.
DNR, do not. And they kept going, okay, well, we're gonna do this and stop, do not. And it was really hard because I know my dad like anything. And it was like a rock. There's nothing that's gonna get me away from that. But man, there were a lot of people who were, okay, we can do this, we can do that, we can do that. It's like, no.
Yeah,
Not.
absolutely. Yeah. And that's what that's like I described. We experienced that too. And then you experience it among family members too. I mean, there were a couple of family members who I think to this day say we should have kept mom hydrated because she was going to recover. It's like she was not going to recover. There was no possibility of it. But again, different
People,
yeah.
people process guilt and care
Exactly.
and love in different ways.
Yeah.
Absolutely. Yeah. Well said.
Here's a resource page. Our number's on there. Washington State Insurance Commissioner, I always put that on there because they have a lot of good Medicare information on there and other information about care services. Columbia Legal Services, Washington Law Help has the documents you can find online that you can print out for durable power of attorney and living will. You can just print those out and fill them out yourself, or you can talk to this Dementia Legal Planning Project about getting those set up, or you could talk to the Bar Association. They'll set you up with an attorney to set the documents up. And then some other information about Medicare. We're always reminding people about COVID, boosters. All of the CDC recommended vaccines are now covered at 100% on Medicare, and that includes COVID, RSV, flu, pneumonia. Shingles is now covered at 100%. So please look into getting those CDC recommended vaccines to keep yourself healthy this winter. So, okay, any other questions? You guys asked some really good questions. I appreciate you sharing. It's always difficult to share family situations that are so challenging, but it helps the conversation and normalize things for one another. So I do really appreciate and admire you guys for sharing those situations that you did. It's useful for me to share them even now, because not a day goes by where I think I probably should have done that, or maybe I should have done that. You're never going to finish it out feeling like you did everything perfectly. You're going to second guess yourself. We all do that as human beings. So You do it the best you can in those situations. What I always say, if you're the decision maker, you really can't make a wrong decision. You might look back a few years and say, well, I could have made a better choice there, but that's the best we can do. So, all right, please grab some material on your way out. Lots of good stuff back there.
Awesome.
Yeah.
Thank you. And thank you for posting this in the Lake Taps newsletter. That's where I saw the.
Wonderful. That's great. Yeah.
So,
And you might be interested, there's a caregiver support group
Mhm.
at the senior center in Sumner that meets once a month.